what I've mentioned of bleeding, stricture, esophageal narrowing, and also Barrett esophagus. Yep. So moving forward to see how the drugs that we are going to study here, or we're going to use later on for patients, how are they? How is their mechanism of action at the level of the parietal cell receptor? You can see this is a parietal cell of the stomach. This is the luminal part, uh, as you can see lower down, where gastric acid is produced and released and secreted into the lumen of the stomach. On the other side, we have the cell membrane receptors that receive whatever is coming in the blood. So this is the blood side. The upper part is the blood side. The lower part is the gastric lumen, and in the middle is the gastric parietal cells. Yep. Okay. Hazik, are you there? Okay. Okay. So we have the muscarinic receptors there, as you can see on the top left. Muscarinic receptors here receiving acetylcholine. Yep. And the acetylcholine is usually produced or is usually released from which nerve? Is it from the sympathetic or the parasympathetic nerve?
Parasympathetic.
Thank you, Amira. You are very active today. Uh, the parasympathetic nerve, does it have a name? Can you name it?
Vagus nerve.
The vagus nerve, which is the 10th cranial nerve, right? Is it the 10th cranial nerve? Yes. Okay. So the vagus nerve is one of the important nerves in the body, and it supplies the heart with acetylcholine. It also supplies the stomach with acetylcholine, and this acetylcholine can stimulate uh, at the end after a series of intracellular events. Okay, activation of kinase enzyme, which will lead to the activation of the proton pump, which is the final step of gastric acid secretion. Proton pump activation, which is called the proton pump, is called the hydrogen potassium ATPase enzyme actually. Okay, which exchange hydrogen ion for potassium ion. That's why this is called the proton pump. It pumps the hydrogen proton in exchange with potassium. Okay. Uh, so other than acetylcholine, the acetylcholine receptors here is muscarinic M1 M1 receptor. Next is the histaminic receptor, to which histamine can bind and can stimulate. Okay, the type of histamine receptor is H2 receptor, at which uh, histamine receptor antagonists or blockers can act to reduce or decrease the gastric acid production. Okay, so acid reducing agents can be anticholinergic, antimuscarinic agents, and can be also antihistaminic agents against uh, H2, specifically and selectively against H2 receptors like cimetidine, ranitidine, nizatidine, and famotidine. We have four names under H2 receptor antagonists. You have to keep them in mind because anyone is a representative of the group. Anyone is a representative of the group. And in MCQ questions, you can be asked like you can be asked about one of the members to represent the whole group. Yeah. So if I say like uh, ranitidine is an H2 receptor antagonist, so the answer is true. Also, if I say famotidine is an H2 receptor antagonist, the answer is also true. So any one of these drugs under H2 receptor antagonist or blockers are representative of the group, especially in the mechanism of action. That's why we have to try to memorize the names under each group as much as we can. Yep. Next is the E, prostaglandin E2 receptor, number three. And this receptor is, as we said, a cytoprotective receptor. Means the more prostaglandin binding here, the more there is, or the less gastric acid is produced. The less the gastric acid is produced, because you can see here there is a minus upon binding of prostaglandin E2 with its cell membrane receptor and activation of G protein, and the G protein will suppress or will block the adenylyl cyclase, the AAC, the adenylyl cyclase. So it will block more synthesis of cyclic AMP. Okay, so this is a cytoprotective factor, prostaglandin, because it reduces, in addition to increasing production of mucus on the other side, by other mechanisms, in addition to increasing the production of bicarbonate ion, it also reduces the gastric acid production by this mechanism that is illustrated here by reducing cyclic AMP. Reducing cyclic AMP. Yeah. And the proton pump at the lower part of the cell membrane, which is on the side, on the luminal side, the proton pump can be blocked by the most efficacious, the highest efficacy anti-ulcer drugs are with the proton pump inhibitors, and the representative for the proton pump inhibitors is omeprazole. Although we have other names under proton pump inhibitors like pantoprazole, lansoprazole, S-omeprazole. So all these are anything that is end with a suffix. The suffix of prazole is a proton pump inhibitor, and that is the drugs that are designed to inhibit the final step in gastric acid secretion. Yep. So how do we classify the drugs that are used for the treatment of peptic ulcer? We classify them mainly based on mechanism of action. So the mechanism of action can be acid reduction, number one, acid reduction, which we have mentioned a few examples of them. And number two, by protecting the mucosa, we call it mucosal protective agents. Okay, those mucosal protective agents are drugs that are designed to be ingested orally, taken orally, and then they will form a physical barrier that separates the ulcer from the invading factors, the aggressive invading factors like the acid and pepsin. Yep. So by this, giving the gastric or the duodenal mucosa more time to heal without being affected by the invading acid and pepsin. That is the basic principle for the use of mucosal protective agent in the treatment of peptic ulcer. Mucosal protective agent can be of two types: colloidal bismuth and sacralfate. We will come to describe each one of them later on in this lecture. So for the acid reducing agents, we have either acid neutralizing drugs, which are the antacids. Example are aluminum hydroxide, magnesium hydroxide, and calcium carbonate. Yep, all these are acid neutralizing agents. They act by binding to the acid and neutralizing it into salt and water. Yeah, because all these are considered to be alkaline products, alkaline materials, yeah, alkaline substances. Uh, the inhibitors of gastric acid secretions are further subdivided according to their efficacy into high efficacy proton pump inhibitors, intermediate efficacy H2 receptor antagonists, histamine 2 receptor antagonists, and low efficacy antimuscarinic agents. Okay, so because of the low efficacy of the antimuscarinic agents, and because they can have other systemic side effects that the antimuscarinic can have on the bladder, for example, causing urine retention, on the colon, they can cause constipation, The antimuscarinic side effect on the eye can cause blurred vision. The antimuscarinic effect on the mouth can cause dryness of the mouth. All these are antimuscarinic, are annoying, disturbing antimuscarinic side effects that led to the lower use or the having these drugs to be less prescribed, especially in the presence of the higher efficacy agents like proton pump inhibitors and with the lower side effect. They are higher efficacy in the treatment, and also they have lower side effect range or profile. Yep. So by this, we have ended the classification. This is just another slide to show you how the drugs are classified. It is a similar way. They are mucosal protective agents in the middle. You can see butyl bismuth, saccharophate, and prostaglandins are also considered as cytoprotective agents or mucosal protective agents because they enhance bicarbonate production in mucus. Yeah, and acids like sodium bicarb, calcium carbonate, aluminum hydroxide, and magnesium hydroxide. Okay. Um, in the treatment of peptic ulcer, we can also use the antibiotics if we find that there is H. pylori infecting the mucosa of the stomach. Yeah, in the presence of H. pylori, will mandate the use of the eradication therapy, which includes the use of antibiotics, including amoxicillin, erythromycin, or clarithromycin, okay, and some tetracyclines. All these are antibiotics against the H. pylori infection uh, that is that can be the underlying cause of the peptic ulcer. Yep. So for the proton pump inhibitors, as we said, omeprazole is the prototypical representative. There are other four additional proton pump inhibitors, which includes lansoprazole, pantoprazole, esomeprazole, rabiprazole. Yeah, all sharing the same suffix. Yes, and all sharing the same suffix at the end. And the mechanism of action is that they cause irreversible, uh, covalent bond, stable, irreversible covalent bond, as you can see here. Irreversible, stable, covalent bond with the hydrogen potassium ATPase enzyme. So by this, it will block and it will inactivate this enzyme irreversibly, and therefore it takes about 18 hours for the enzyme 18 hours for the enzyme to become resynthesized. So that's why they are considered uh, to be the drugs of choice. Yeah, the drugs of choice for the treatment of both duodenal and peptic ulcer, and also for the treatment of gastroesophageal reflux disease, GERD. Yeah. They are able to inhibit both the basal and food stimulated gastric acid secretion by more than 90%. More than 90%. Yep. While for the for the histamine receptor antagonist, H2 receptor antagonist drugs, they are only capable of blocking less than 90% of gastric acid secretion during the nighttime, nocturnal gastric acid secretion. So that's why the proton pump inhibitors are considered as higher efficacy because they can block more than 90%. And the onset of action happens after 1 to 2 hours after the first dose, and slightly earlier, maybe 30 minutes after omeprazole. Yep. So these drugs are formulated in a way to be released in the duodenum because those are alkaline basic drugs that needs to be absorbed lower than the stomach in a pH which is higher than 7. Yep. So in order to have the proton pump inhibitors absorbed, we need to delay their absorption lower down until they reach the lower